You're listening to the Better Women series of Matters of Engagement. We're a podcast examining issues at the intersection of health, healthcare, and society. I'm Jennifer Johannesson.
And I'm Emily Nicholas Angle.
We're excited to bring you this special 5-part series in collaboration with the Canadian Cancer Society and Women's College Hospital. As you'll soon learn, they joined forces to address one of the pressing issues facing both public health and primary care medicine, and that is how to support people in preventing chronic disease through lifestyle behavior change.
Stay with us for a journey through the Better Women Research Project, and we'll learn together about its potential for positive impact on the health of Canadians everywhere.
It's no secret that our healthcare system here in Ontario is, well, drowning. And it's happening everywhere, from emergency rooms to primary care to routine procedures and specialized treatments. There are long wait lists everywhere as a result of understaffing and underfunding, and a lack of prioritization in terms of addressing these issues. Now, patients, of course, experience the highest burden as increased risk to their health and well-being. And frontline healthcare providers feel it too. They're getting burnt out and frustrated.
There's this famous story about a group of rescuers beside a river. It's one person after another they're dragging out of the river who's near drowning. And they're working their butts off. And all of a sudden, one of the rescuers stops and starts walking upstream. And the other rescuers are, "Where are you going? We have all these people coming to save." And he said, "I can't keep doing this. I got to figure out where they're coming from and solve the problem upstream."
That was Dr. Noah Ivers. He's a scientist and family physician at Women's College Hospital in Toronto and the evaluation lead and co-principal investigator of Better Women. He uses the term upstream. We're going to hear that a lot in the upcoming episodes. It's a bit of a shorthand to refer to the idea that if you catch problems where they start, you might not get overwhelmed later. Sounds simple, right?
What makes it not so simple in reality is that going upstream to address things early, well, it can take time. It can be expensive, and it can take a lot of research and planning to understand and uncover what the root issues actually are. So instead, we tend to fall back on quick fixes and short-term investments.
Yeah, this mindset is a huge barrier to making positive long-term change, whether you're talking about an entire healthcare system or whether you're talking about an individual person trying to get healthier.
Yeah, this upstream-downstream analogy is so relevant. In this podcast series, we're actually going to explore one way we could indeed get further upstream and potentially help prevent all kinds of chronic diseases from getting worse or maybe even starting.
Well, we actually have a really big story to tell, and there's a lot to cover. So stay with us as we dive into the Better Women Research Project. We're bringing you 5 episodes, including this one, to explore how a shift towards prevention and involving peers and community on their journey to wellness can potentially make a huge difference to health outcomes.
So in this series, we're profiling a pilot initiative and research project called Better Women. It's actually work that's been going on for a long time. Better Women is an extension of the Better program of research, which we'll come back to a bit later. But for now, in this extension of the broader program, they're training volunteers, people like you and me, to support others who are looking to make behavior and lifestyle changes to achieve their health goals.
A bit like an accountability coach.
Yeah, kind of like that. Better Women has many facets to it, and we can't possibly cover it in one episode. So, we have a whole series lined up to discuss disease prevention, peer health coaching, health system improvement, research and community partnerships, all the things society needs, especially now with our overburdened health system and ever-growing inequities in healthcare services and health outcomes that are experienced by many communities. And over the course of this series, we'll be bringing you the insights and expertise from the Better Women scientists, researchers, physicians, cancer care specialists, prevention practitioners, and peer health coaches.
In this first episode, we're going to lay the groundwork and hear from several people who will help us connect the dots. What led the teams at Women's College Hospital and Canadian Cancer Society to team up and really try to figure this stuff out? And what possibilities are they discovering? In the upcoming episodes, we'll do a deeper dive into the research project itself, talk to some peer health coaches about their experiences and insights, and, of course, share the findings of the research study and discuss the potential of peer health coaching in the future.
It's a lot to cover.
Everyone we're talking to in these episodes is involved in the Better Women program in some way or another. But it might be hard to track after a while, like who's saying what and who's doing what role. So if you get lost or confused, please refer to the show notes for a full transcript and for everyone's individual role in the project. We'll also be recapping all of the featured voices at the end of each episode.
So, Jen, are we done with all that intro stuff now?
Yes, we are. Let's get back to unpacking this upstream-downstream problem. We're going to hear from Dr. Matt Arava. He's a researcher and primary care doctor in Barrie, Ontario, and he knows about these issues all too well.
I think if we focus on the short-term outcomes, we fall in the trap that we've always fallen into. So we have a lot of investments in our acute care sector. In our acute care sector, the big users are cardiovascular health, respiratory health associated with smoking, and cancers. If we go to what's causing their ultimate disease process and we try to prevent that, then we're going to have savings. The short-term data will not show us a reduction in emerge visits or reduction in hospitalizations. But if we can look at the data and say, okay, how many more women can we get screened for cancer? And then how many new cancers will we detect? Or how many people will we get to quit smoking and prevent the COPD and prevent the cardiovascular disease down the road? If we can show that data and then have a true understanding that that will reduce our acute care costs in the future, I think that's how we would win the battle of upstream care.
Yep, there's that word again, upstream. So, upstream, downstream, short-term, long-term. What we're really talking about is prevention. So, what is prevention and how does it relate to reducing healthcare costs as well as reducing negative health impacts down the line? Well, prevention is really all about reducing risk, stopping problems from getting worse, and possibly even ensuring that problems just don't start in the first place.
And primary care, as it stands, isn't really optimized to address prevention for most patients. Because of billing models and time constraints, patient overload, it's just all too much. And I mean also, many people just don't really see their physicians until there's a problem. So, we're back to a more fixing model of care.
An organization that's really thought long and hard about prevention is the Canadian Cancer Society. Their fight against cancer is a multi-pronged approach, and that includes research, education, support services, advocacy, and, of course, prevention. Let's hear from Catherine Hebb. She's their Vice President of Cancer Prevention.
If you ask 10 Canadians on the street, you'd get 10 different answers on what does the term prevention mean? And many people will talk about, well, we just need to tell people not to smoke, and we need to tell people to exercise and, move more and eat better and whatever. That is a small part of what prevention is. And we know that just telling people these things often doesn't work. And we know that people's environments, whether they be social environments, physical environments, work environments, occupational environments, all of those have a profound impact on health outcomes.
Susan Flynn also works at the Canadian Cancer Society, and she's a director of cancer prevention programs. She admits it's a big task trying to get people to go for regular screening, and there can be extra barriers for certain communities.
We know that generic messaging is not as effective as messaging that's tailored for a specific community or population. In our work, through data that's available in the provinces and territories, we look at who is bearing the biggest burden of cancer risk, which communities are in Canada. And so, for example, if you look at screening, newcomer communities, racialized communities, to us LGBTQI and Indigenous communities, their cancer is getting detected at a much later rate than the general population. And general population messaging is not obviously having the impact. Just saying, hey, go get screened is not having the impact. So you have to take a step back and look at why is this community not getting screened? What are the barriers to screening? And so that could be a number of different things. And it takes a multiple pronged approach to address that.
So there's a bunch of factors around communicating the information in an accessible and relevant way, and reaching people that you need to reach. I mean, posters on the subway just really aren't going to cut it, especially if that's your only approach.
This is a good time, actually, to talk about the work at Women's College Hospital. The research team is interested in prevention as a kind of community-based approach where it's not just the doctor supporting patients, but there's a whole network of support in a variety of roles. And one of those supporting professionals is the prevention practitioner.
Yeah, the prevention practitioner is someone in the primary care practice trained to provide expertise in chronic disease prevention and screening. They work collaboratively with patients to set goals, and they develop a unique, personalized prevention prescription for each patient. Women's College had actually conducted a previous study, it was just called Better, which focused on understanding whether and how to utilize prevention practitioners in primary care.
Right, and when they launched Better Women, which is an extension to the Better Project, they brought in Dr. Eva Grunfeld. She's the one who actually led the original Better research. Her historical knowledge of the Better program and, of course, her expertise around prevention were invaluable to the Better Women project. We asked her to explain, in the context of the Better research, who takes on the role of prevention practitioner.
It's explicitly not the family doctor who does it. It's explicitly any health professional that works within the family practice, such as a nurse, a pharmacist, a dietitian. Any health professional can be trained as a prevention practitioner. The value of placing it in the family practice is that they can then communicate directly with the family doctor, where the family doctor's input is required. An example might be somebody who has high blood pressure and needs to have their medications adjusted. Well, the prevention practitioner who works in that practice can then link with the family doctor and say, please see this patient because they need to have their medications adjusted. When I mentioned the upstream factors, those are the things that we all pretty well know. Exercise, diet, smoking cessation. So those are all specific prevention activities. And what the prevention prescription does is through the prevention visit, if we take the example of exercise, the prevention practitioner learns what the patient is currently doing, takes the best evidence that we have about what is recommended, and then gives suggestions for how they can meet those objectives. And then the outcome we looked at is, did they meet that objective?
So the prevention practitioner is actually in a position to take over all the reminders and the follow-up and to check in with the patient and then report back and confer with the doctor. It makes a ton of sense, but still, it's a lot of work. And that's why Dr. Arava talks about involving the community more broadly.
So the idea of getting communities involved in our health, I think, is something there's a gap. Public health has worked really hard at this, but to move the population to be active and interested in their health, I think, is a really important thing. And I think patients kind of crave that. They want to have someone who might have a lived experience of going through something. From the literature, we know like smoking cessation, when we send people like the smokers helpline, people who have quit themselves and help people walk through smoking, that's been more successful than a physician telling them that they should quit smoking. And I think most people already know that they need to optimize their diet, optimize their exercise, and get up to date for cancer screening. How do we get them to move that needle? I think is, if it's a community notion that, hey, this is something that's important for all of us, and how can we help each other do that?
Yeah, the pressures on family medicine and primary care are already so immense. It's almost impossible to imagine that a family doctor can also actively address prevention in a meaningful way.
Yeah, they're pretty stretched. Here's Dr. Ivers again.
The broad range and scope of things that fall under the rubric of primary care is so big that there's no way that a family doc could do it all. There's no way that a nurse practitioner can do it all. There's no way that any given one clinician can do it all. We need to share the load. And the broader evidence in this realm around sharing the load is called task shifting. And within that, we started thinking, what's affordable? What is the evidence for task shifting around health behavior changes? And that led us down the road towards, peer health coaching and community health workers. And so then there's a whole literature around how do you train such people effectively? And we partnered with folks that had already done work to train community workers around cancer survivorship, for instance, and then adapting things for that. And so I think it would be fair to say at every step of the way, because we're academics and, pointy heads and whatnot, we like asking the questions of, what's the evidence? We shouldn't just make things up. We shouldn't reinvent the wheel. We should build on what we know.
One thing they did know going in, thanks to the original Better study, was that having a prevention practitioner is very helpful to a primary care practice.
Yeah, so that was the focus of Dr. Grunfeld and the Better program. And there's also a solid body of research showing that peers or community members can be an effective bridge between patients and practitioners. These are people trained to support others who liaise with a network of professionals.
And they also knew that community involvement and co-design are vitally important for building trust and relationships and ensuring that services and interventions are actually appropriate and useful and meaningful.
Yep, but as Dr. Ivers says, lots to be learned still. And this is where partnerships become really productive and helpful. So in the case of Better Women, it was the Canadian Cancer Society, with its experience in cancer prevention and community outreach and peer support, and then Women's College, with their team of researchers and physicians who are interested in chronic disease prevention, implementation science, and health system improvement.
Yeah, a perfect match.
We keep investing in disease management, and we forget that so many of the diseases are coming from a set of common, fundamental health behaviors that people need help with from their broader healthcare team, whether that's cancer screening tests or screening for diabetes or managing high blood pressure or managing heart disease. We're talking about healthy diet. We're talking about physical activity and helping people come up with plans and setting specific goals and making behavior changes around those things. Needs to be a greater focus of what we do unless we want to keep feeling like we're dealing with emergencies all the time.
Okay, right. So we're back again to the short-term, long-term problem. But we already know it's not enough to just tell people what to do or to set goals and then cross your fingers that it's all going to work out.
Self-efficacy is like an old concept by a guy called Bandura, a psychologist, but basically, more or less, it means confidence. And so do I actually believe that I can do the thing? Whether that thing's, go to the gym more, whatever the thing is. And in fact, in the health action process approach, we break down the confidence into a variety of bits. It's about getting going. It's about keeping it going. And really importantly, it's about acknowledging that I'm probably going to get off track at some point, and do I have the confidence to get back on track?
Yeah, I like the framing of it as confidence, a kind of capacity building in the patient where they're learning all kinds of skills and given lots of tools. Except it's still a really big ask to expect behavior change. They found out in the Better study that prevention practitioners play a big role in helping to set goals. But then there's this next step of integrating everything into your life and actually building that confidence. What happens when you're on your own, without all that medical follow-up?
Yeah, it's a good question. But the prevention practitioners don't just leave you hanging. They do try to set patients up for success by not only following up on a regular basis, but also passing along resources and referrals. So it's not just go make some changes and now you're on your way. Here's Dr. Ava Grunfeld again.
So one of the things that prevention practitioners would do before they begin this professional role is do an environmental scan of resources available in their community. So they make a direct link. Similarly, for alterations in diet, they will then make a direct referral to a dietitian who is in the practice. So it's not just making the recommendation, but actually the next step, the next handoff to facilitate that individual achieving those objectives. At the same time, the reason that we are really excited about Better Women is because we hope that that peer health coaching addition will really help with the more complex and difficult to alter behavioral aspects.
So this is really the heart of the Better Women Project, the peer health coaches. Their work picks up where the prevention practitioners leave off.
Okay, so let's recap. In the context of the Better Women program, a patient's journey starts with a physician who identifies a need for prevention support. The patient then sees a prevention practitioner to track their health-related data and help set health-related goals. And then the peer health coach helps to support behavior change related to lifestyle.
We'll hear more about the specifics in an upcoming episode, but yeah, this model presents an amazing opportunity to rethink, well, everything.
So let's bring in Dr. Aisha Lofters. Along with Dr. Noah Ivers, she's co-principal investigator of the Better Women Project. She's a scientist and family physician and holds a chair in implementation science. She makes the case for big change.
I think we are all right now very aware that we are in the midst of a primary care crisis. So I think everyone's thinking about how do we do things differently? Because, this idea of we're just going to make a bunch of family doctors appear out of thin air feels a bit unrealistic in the short term. I think, we're going to be increasing medical school and residency spots in the longer term. But in the shorter term, I think we're all thinking about how do we do healthcare differently so that, we're able to take in more patients into existing practices, et cetera, that we're able to think of other roles. Prevention is never hot and sexy for attracting people's attention, but it is it's much better to prevent something than have to then deal with it, to be in the emergency room for an issue, to be going through cancer treatment or dealing with cardiovascular issues. So prevention really is, quite honestly, a cost-effective approach. So you have a health professional who's a prevention practitioner who's supporting prevention. You have somebody who is a peer who's been trained, who's doing peer health coaching. So we're taking things off of the kind of overworked family doctor's plate, freeing up their time to deal with other patient issues, and we're bringing in other members of the healthcare team. And in the times that we're in right now, I think we need to be looking at models like this to think about how can we really support our healthcare system.
So can we just take a second here to define what it is we mean by peer? Because I think about all the things that I identify with, like I'm a mom, I'm middle-aged, I have a mixed race background, and I also have a specific health history and profile. So I don't actually know what I would highlight if I were being matched with a peer health coach.
Aisha did clarify that generally, how you define peer is kind of up to you. What do you relate to?
Someone might say, I'm a smoker, and all that matters to me is I want somebody who has dealt with quitting smoking. There might be somebody else who says, you know what, I come from this particular country and I want somebody who understands my culture, so I'm not constantly explaining things to people or not having to kind of take an advice and know it's not going to work within my household. So for some people, that could really be what's being a peer is about.
What strikes me is that at the heart of prevention is self-care. And this project focuses particularly on women who often bear the most burden when it comes to caregiving and looking after others and possibly neglecting their own health. And this is a well-known issue. Here again is Susan Flynn from the Canadian Cancer Society.
So I think it's understanding people's challenges, whether it's system challenges or the built environment, and recognizing that existing in those environments will impact your motivation and your ability, your self-belief, that you can do this and that this is important. If you're somebody who's very busy, it's understanding that it's important for you to make time for yourself. We heard in some communities that women don't have time to take care of themselves, but then if you can ask them to think about, well, what happens when you get sick, or you get cancer, then that's going to have a bigger impact on your family than you taking the time to invest in your health.
We're going to give the last word here to Christine Brookaleri. She was a peer health coach with Better Women and experienced a long cancer journey herself. Even through all the training and skills building and the health coaching, she really boils down the importance of the work to a pretty common and basic need: human connection.
You keep hearing nowadays there's like an epidemic of loneliness. I just think even just having a connect with someone once a week is, for a lot of people, something to look forward to. The benefit of it is that you're trying to do things that will improve yourself and help you feel better. And who doesn't want that, right? Someone rooting for you, someone being your cheerleader, having a partnership with you, not judging you, being compassionate in where you are, and helping you feel better is awesome. It's beneficial in so many areas, prevention and through treatment.
Thank you so much for tuning in. Next episode, we're getting into the nuts and bolts of the research project itself. If you've ever been curious about some of the components of research and didn't have anyone to ask, be sure to listen. Bye for now.
See you next time.
This series on the Better Women Project was brought to you by Matters of Engagement in collaboration with the Canadian Cancer Society and the Better Women research team at Women's College Hospital.
Special thanks for editorial and administrative support provided by Karen Kuzmich, Christina Macri, and Shabina Amlani at the Canadian Cancer Society, and to Natasha Kathulagoda at Women's College.
And a big thank you to all our guests on this episode. Dr. Noah Ivers, scientist and family physician at Women's College Hospital and Canada Research Chair, Tier 2, in implementation of evidence-based practice, and co-investigator of Better Women. Catherine Hepp, Vice President of Cancer Prevention Programs and Services at the Canadian Cancer Society. Susan Flynn, a Director of Cancer Prevention at the Canadian Cancer Society. Dr. Ava Grunfeld, Officer of the Order of Canada, Physician Scientist, and Professor Emeritus at the University of Toronto. Dr. Matt Arava, Family Physician at Royal Victoria Regional Health Centre, Lecturer in Family and Community Medicine at the University of Toronto, and recipient of the Tristan Lawson Distinguished Fellowship in Child Nutrition and Community Engagement. Dr. Aisha Lofters, Scientist, Family Physician, and Chair in Implementation Science at the Peter Gilgan Centre for Women's Cancers, Women's College Hospital. Also, co-investigator of Better Women. And Christine Brookaleri, peer health coach with the Better Women Project. This episode was written and produced by Jennifer Johannesson and Emily Nicholas Engel. For a transcript of this episode and for more information, please visit our website at mattersofengagement.com.
The end of the Canadian Cancer Society's CIBC Run for the Cure is just the beginning, because the funds raised through the run continue to fuel life-saving breast cancer research, enable clinical trials that improve outcomes and bring new hope, and help patients every step of the way with vital support services. Join us October 5th and make an impact that lasts far beyond. Sign up at cibcrunforthecure.com.